Hello, everyone. Hello, welcome to our Friday forum. Hello, hello, hello. Thank you all for logging in from all over the world. We're really happy to see everyone. Please feel free to turn your cameras on if you want to speak, or raise your hands if you have any comments that you would like to make. Hello, nice to see everyone. I'm very happy that we have a Friday forum talking about investing in TB now and why it is important that we invest in TB. All of us are working in TB, so I think we know the reasons, but to hear from our esteemed colleagues on the panel today and to hear from everyone, to have discussions on what are our best arguments, looking forward to discussion. I'm really, really happy that we have great colleagues on the panel to talk to us, and a wonderful moderator, Ekta John. She's a journalist as a background from India, and she works now as a campaign manager at Results Canada, and she will guide us through the discussions today and lead the panel. So looking forward. I'm handing over to Ekta. Ekta, the floor is yours. Go ahead.
Thank you so much, Petra, for that wonderful introduction. When Petra and Joel asked me if I was interested in moderating this discussion, I didn't miss a beat to say yes. If my years in health advocacy and journalism has taught me something, it's this: no one person, no one organization, no one country lead the fight to end long-standing epidemics like tuberculosis. What we need are allies, what we need are partners, and what we need is global solidarity. And this discussion is testament to that. We have panelists and participants from different parts of the world fighting the same fight of health and well-being for all, and speaking the same language of equality and equity.
For 1.5 hours.
It would be great if all of you could put yourself on mute unless you want to speak up. Thank you so much. So without much time, let me briefly introduce the panelists we have. We have Mohammed Yasin, who is a senior TB advisor at the Global Fund to fight AIDS, TB, and malaria, who's based in Geneva. We have Agatha Wambuga, the regional project officer of Comesha TB from Kenya. Raman Shankar, director of global health strategies from India. Austin Obifuna, vice chair, community delegation at Stop TB Partnership. And Vinita Gupta, the director of the Action Global Health Advocacy Partnership based in Washington, D.C. I'm not very sure, but also a big shout out to Funke, our TB champion from Nigeria, who I think is on this call. And thank you all so much for coming on board this critical discussion. So before I open the floor to our panelists, a couple of quick housekeeping points and an introduction to our discussion today. In the spirit of allyship, as Petra mentioned, we deliberately didn't have a strict structure as such for this discussion. We want to keep it as informal as possible. So although my questions will be directed at the panelists, if any of you have anything to add at any point, please post your questions in the chat or raise your hand. And I would really appreciate it if all of you could stay on mute and unmute when you want to speak up. So to the panelists, owing to time constraints, we would really appreciate it if you could limit your response to 3 minutes or less. So thank you. So coming to the discussion today, the main focus of our discussion today is investing now in TB. Today, attaining SDG 3 and more specifically target 3.3, which calls for ending the epidemics of AIDS, TB, and malaria, is an even bigger yet more critical challenge requiring an unprecedented level of action. One such course of action is calling for investment in the Global Fund to fight HIV, AIDS, TB, and malaria. For those not familiar, the Global Fund is a unique global partnership that has invested more than $53 billion over 20 years, saving 44 million lives and reducing the combined death rate from the 3 long-standing epidemics by more than half in countries in which the Global Fund invests. And then COVID-19 happened. The pandemic took a toll on already overstretched health systems, reversed hard-won gains in the fight against TB, and increased inequities. As people at the grassroots, many of you must have seen firsthand the impact COVID-19 had on the ground. For the first time in a decade, the number of people dying from TB has increased. So the Global Fund is replenished in 3-year cycles, and the 7th Replenishment Conference will be hosted by the US this September. For this replenishment, the Global Fund needs at least $18 billion, This is the absolute minimum required to get the world back on track towards ending tuberculosis and HIV and malaria, to build resilient and sustainable health systems, and to strengthen pandemic preparedness. Because the next pandemic is not too far out, and we can't continue to pay the cost in lives. So with this, I'd like to open the floor to discussion. And my first question is to all panelists. In the context of investing in TB, why is the Global Fund such a critical mechanism? And what have been your most compelling arguments and to policymakers to invest in TB? And Mohammed, would you like to start on this, please?
Yeah, thank you very much. Good morning, good afternoon, good evening, everyone. Thanks for joining to this interactive section, and thanks to organizers for the opportunity. I think you have already highlighted about the Global Fund and why we need to continue investing, and why we need that $18 billion for the next 3 years. As you might have seen in the Global Fund Replenishment Investment Case, that additional funding for the next 3 years, $18 billion, would contribute to saving 20 million lives and reducing overall mortality from the 3 diseases by 64%. This is what the Global Fund supported programs and countries and all the partners would be contributing to. And so that it is really critical that we get that money to get back to track, but also to accelerate and ending TB, HIV, malaria, and building health system. Global Fund, as you all may know, is the main source of international funding for TB, more than 70%. While we all understand that most of the funding for TB comes from domestic funding, but the Global Fund investment in TB for the last 20 years, at nearly $8 billion, helped to scale up the fight against TB and improve access and engaging all the communities and affected people. And investing on TB from the economic point, it had a huge return, and one of the investment area where you would see investing $1 would return over $40. So there is strong argument on that. But the issue is that what will happen if we don't really invest on TB now? So as you all know, TB is an airborne disease. We all are breathing the same air, and if we don't address TB somewhere, that would be anywhere, everywhere, very soon. And we also know that drug-resistant TB it's actually a security threat, a health threat, and it would affect many more people. And we know that TB kills more than 1.5 million people every year. No other infectious disease, of course, COVID came in, and otherwise TB is a leading cause of this. So it's really about saving life and huge economic return. And we do have tools to diagnose, treat, and prevent TB, and very compelling reasons for us to invest and continue investing more on TB. And if the Global Fund replenishment is successful, then that means TB would receive more resources and would be able to treat and diagnose and treat and prevent TB more globally. Over.
Thank you so much for that, Mohammed. Vinita, you're a physician, you're a human rights lawyer, and a lifelong health equity advocate. And your experience and background speak a lot to TB advocacy, because TB is often seen as a social disease with a medical aspect. So what, in your perspective, has been the most compelling case to invest in the Global Fund and TB? It would also be great if you could briefly touch on our ongoing Fight for What Counts campaign.
Okay, so thank you. And so honored to be with other panelists and all of you. And you know what, I feel like invest in TB now. My question back is, why not now? Now is the moment, right? As a public health physician, and Dr. Aman, you'll be able to agree with me on that, that when I was a young physician, health physician in India, and we all were implementing National Tuberculosis Program, we firmly believe that disease will be a disease of past soon, in near future. And here we are today, quarter century after, and we are not only still dealing with it, we actually slid back on the gains during COVID. So I just can't fathom that how we are still struggling with so many deaths, losing lives after a quarter century. You know, Global Fund has been around. I remember Global Fund being the most credible organization we used to look up to, and we still do. It's one of the best mechanisms to invest in to deal with that, right? So I feel like this has been the biggest killer for so many years. It's totally preventable, right? And then what is it? Then why do we need to convince policymakers? COVID didn't need convincing. Why is it, right? So that segues into my other passion is health equity, right? So it's a matter, tuberculosis is seen as a disease of LMIC and poor within that, right? So it is from human rights perspective, from right to health, from SDG, from financial perspective, you name it, every perspective, we know that it has been a neglected disease and we need to step up on investment. And PHC framework, right? PHC framework provides us what we need to tackle this biggest healthcare challenge, right? It can handle TB, it can handle COVID, and other emerging health crises, MNH, right? Maternal and newborn health. All of those can be tackled, and the money invested in a global fund can not only do the TB, tackle with the TB as a disease, but also spread out all the benefits in stronger systems, you know, community-based approaches. So I feel like it's just mind-blowing that when my dad was a kid, he had the same vaccine. I had the same vaccine. Generations since are having the same vaccine, right? So COVID vaccine, we know we have resources. We know that if we recognize the need, global community, all the powerful northern donors have the money to muster and mobilize resources. So why don't we do that, right? So for example, for COVID in, since 2020, we have mobilized $9 billion. $9 billion just from US, right? And in 2018, for the global, for the tuberculosis R&D expenditure, $906 million. See the difference in only US could mobilize 9 billion. So we have that opportunity, we have it now. And then I would just make another point is policymaker, pharmaceuticals, supranational philanthropic entities, everybody is doling out health equity phrase as if we are doling out popsicles on a summer birthday party for kids, right? So it's a time to hit it. Like, hey, walk the talk. It's an equity issue. So I think it is very crucial. And the last point I would make is SDG commitments to end tuberculosis by 2030, we won't meet the goal if we don't step up. We are already late. So let's get back on track. Let's invest in Global Fund. Let's put our resources behind in structures that would not only support ending TB, but strengthen the systems across the board. We have many mechanisms, including PHC framework. Thank you. Back to you, Ekta.
Thank you so much for that, Vinita. And my next question is to Austin. So Austin, you've been like a former vice chair of the Ghana Country Coordinating Mechanism for Global Fund. So you've probably seen firsthand the impact the Global Fund has had on TB care and prevention on the ground, while also being included to global advocacy efforts. So what, according to you, has been the strongest case to invest in TB and the Global Fund?
Thank you, Agatha. And once again, my greetings to everyone, wherever you are. Good morning, good afternoon, good evening. And thank you to the organizers as well. First of all, I think a well-replenished global fund, fully funded global fund is what we're all seeking for. We even want more, to make sure that TB is actually adequately addressed. Speaking from the idea of Global Fund. I think we know we are in a global village now. The world is so interconnected that you cannot speak about a particular country without referring to a place. And one important thing that Global Fund has done is actually building strong partnership at the country level, building synergies for sectors to be connected together so that we do not allow diseases to be tackled by just the public sector, but complementing each other, both the private sector, the civil society, and the rest working together. And this partnership could have never, in some countries, because of the way they are politically aligned, may not have been able, to be possible, if not with the way the Global Fund, came in with strategies and the structures that allow such kind of dialogues and discussion to happen in the countries. And that thing is that if you look at the Global Fund formation, these are, it comes with a lot of differences in terms of how we address issues, because the world may be unique, but the most important thing is that we are coming from using different strategies from different countries, sharing ideas and bringing it at one hub for countries to be able to understand how to address some of these issues. There's no one simple country that will tell you that they know the best way to be able to address these issues. And COVID has actually taught us a lot of lessons. You see how political leaders rallied together. You see how civil society were able to bridge the gap between treatment for other diseases, especially like TB. They're able to work, and with the support of the Global Fund, able to move services to people, people who ordinarily may not have been able to have the opportunity to be able to get, to be reached. So this Global Fund has really, really improved, how we tackle diseases. You see the effort Global Fund made in terms of HIV awareness and treatment. Now, when we talk about stigma, we're actually discussing only stigma in TB and mainly because there's no longer a stigma in HIV. Nobody talks about HIV is just like a common normal disease, but people still discuss stigma around TB, which means we still need funding. We still need to address TB, adequately and holistically, not just addressing it in a silo. And that thing is that if you look at the Global Fund investment case that is being shared out now, they will tell you that even before COVID, we are not on track with TB. We are not on track. But even with the COVID has actually exacerbated all these areas in terms of, and what is actually fueling the increase, the TB death increase is actually undiagnosed and untreated people. So what it tells you is that we need to find a way for countries to be able to utilize the new tools that we have. We have countries that are still using microscopy. They are still using tools that are made 70 years ago. How are we going to be able to get to that extent in terms of our being ambitious, with our targets, our treatment, even meeting the high level meeting targets? It's never possible. Countries are doing prevalence survey to be able to understand the epidemic in their countries, and they are using, the new tools to be able to undertake such prevalence survey. At the end of the day, they roll back again to now use, the old outdated tools, which will never get you anywhere. And also, we have not even been able to use even with the treatment as well. We need to improve on our new. WHO is churning out a lot of new treatment guidelines. Countries have not been able to adapt it. So if we are talking about people-centered approach, let's focus on making sure that we take up these new tools. Thank you.
Right. Thank you so much, Austin, for that. I mean, yes, COVID was a lesson for all of us. And I'd like to request the speakers to keep your presentation for less than 3 minutes because we are constrained by time. Raman, I'm coming over to you next. You've led policy and advocacy efforts among political leaders and civil society and the media in India. What has been your most compelling case in investing in TB and your experience advocating for the Global Fund, if any? Over to you, Raman.
Thanks, Sikta. And those were really great introductory remarks and great to be part of this panel. I think there are different levels of arguments that we've used with different sets of stakeholders. I think first up was really important to really talk about the true extent of the burden of the disease, right? And I think even the WHO report last year showed that around 4 million people were actually missed. So we actually have no idea where they went. Did they even get care? What kind of care they got? Were they treated? How were they treated? Did they, stop treatment? Did it lead to drug-resistant TB? We have no idea. So I think bringing that to the fore, that there is this large number of people who went, who we have no idea what care they got, is very important to make. And it also, I think, that's why we also talk about the hidden burden of TB, right? And I think bringing that argument to the fore is very important to also show the severity of the issue itself. I think the second one is is the economic argument, right? The billions of dollars lost in, TB-related health expenditure, in the loss of livelihoods, but also the future economic loss that we have. These patients who are missed out, there might be emergence of drug-resistant TB. We know that there is drug-resistant TB being primarily, being transmitted even through primary ways. So, and that in the end is going to cost the public exchequer much more. So I think the economic argument too really holds. And finally, I think the moral argument, that like the others very clearly put out, we know how to manage it. We have the drugs that we have. Yes, we need better drugs. We need much safer drugs, but we do have drugs. And it is a completely curable disease. And my colleagues at WHO keep reminding me that we shouldn't even have one single TB death. And the fact that, 1.5 million people die every year is deeply troubling. And I think these are the kinds of arguments we've made. And even the case for private-public partnerships also emerges from this missing million, right? And I'll stop there and I'll come to that when that kind of question arises. Thank you.
Thank you so much for that, Ram. And I know the most frustrating part of this is people are dying of preventable and curable diseases. So now moving to Agatha. Agatha, you've had experience managing health and community development projects in Kenya. Could you briefly touch on the impact COVID-19 has had on TB elimination strategies at the grassroots and the extent and urgency of the need to act right now, and how global financing mechanisms like the Global Fund can help? Over to you, Agatha.
Thank you so much. And indeed, I've been involved largely with managing of TB cases. And just to mention, to a great extent in the private sector. And with the COVID-19 entry, it has quite hampered the access of TB management for our patients. And not to mention, we have also missed a lot of TB cases in the process because of the cross-cutting symptoms, And as a private sector and in the spirit of being responsive, it's been quite in the front advocacy. Just try and, educate the public on presentations of TB that cross-cut with COVID and how, therefore, we can be able to improve on access. In the funding parameters, it's been really at the forefront of the policymakers to try and come up with policies that improve access for the Kenyans, and especially to make the private sector also really, really accessible and able to handle some of these events that come.
Thank you so much for that, Agatha. I'm conscious of time. So we'll be moving to the second part of our discussion. Does anyone have any questions or insights to share with our panelists? I'll give you 1 minute to raise your hand or put your questions in the chat box. Does anyone have any questions? Okay, so I think I'll move to the second part of the question, discussion if there's no question. Mohammed, I mean, this is addressed more to you, and then we'll move to the other panelists. You've been a member of several global task forces, including PPM. So how does the Global Fund engage or incorporate PPM in TB elimination and care? And it would also be great if you could speak to the challenges with funding for PPM and the opportunities to advocate for TB and PPM to be a bigger part of the Global Fund replenishment's discussion. Over to you, Mohammed.
Thank you very much. Yes, investment in private sector engagement is critical. As you have already mentioned, the Global Fund is a unique public-private partnership mechanism. And I think we are all witnessing that the mechanism has been working very well. And we believe that addressing all this, the 3 diseases and the building the health system is not the role of only government or public side. That's why investing through the private sector is also a critical component. Actually, it's a critical component for TB, and we have been doing some analysis of our investment for the last 20 years. And for TB, we have seen an increasing trend in overall TB investment for private sector engagement. Given that several approach and models, innovative financing components incorporated, and the Global Fund investment has been used as a catalytic and supporting those scale up of those innovative intervention in several of the countries. And the data already, our investment shows that during this round-based funding cycle, the investment on private sector was very small, only about 3% of the Global Fund TB portfolio. That increased to about 4% during our new funding model first wave, and then increased during second wave, and reached to over 14%. And this is not just overall the volume, the amount of money, but we are also encouraging to bring private sector implementers, like receiving the Global Fund funding directly as principal recipient or sub-recipient. A good examples in Pakistan, in India, and in Nigeria recently as well. These are opportunities how the Global Fund funding mechanism overall is contributing to bringing more private providers to addressing TB. But as a part of the momentum in finding the missing people with TB, and we have been looking at who are they and where are they and how we can find them. And in most of the countries, especially in Asia, most of the missing people are actually going to private sector. That's the first point of care for most of the people in this part of the world. And that's where we need to go, and we need to follow the people. Otherwise, we would never be able to end TB. And that was an opportunity for Global Fund and countries to receive additional funding as part of private sector engagement. And we know there are some challenge. One of the challenges is actually an overall perception from the private side and the public side as well about each other. That's really like a hurdle to scale up some of the innovative intervention. And the policy-related issues that in some countries, TB is not a notifiable disease. And it's difficult actually to give more money to private sector, including the gene experts, the drugs, and so on in some of the countries. You can't really put. From Global Fund side, we don't really have any issue on that one. As far as our investment contributes to finding and treating and preventing TB, it could be in the public, private, at the community level, anywhere within the country. The main objective is really to saving life, ending TB. And for that, the Global Fund investment, not only as part of the overall allocation, but as part of catalytic funding, where countries receive additional money for finding the missing people, the private or PPM component has been scaled up through that as well. Over.
Thank you so much, Mohammed, for that. Follow the people. Thank you for articulating that so well. And Raman, if I could move to you, I know, like firsthand, I've seen how private providers play such an important role in providing TB care in India. What are some of the challenges you are seeing with funding for PPM on the ground? And based on your experience, what would you say are the key points to advocate for TB and PPM in global health discussions? Over to you, Raman.
Thanks, Ekta. I think it's important to first acknowledge that traditionally we have not engaged with the private sector in a very systematic manner, right? So there is a need for a change in mindset that needs to happen across the board, right? From program managers to even the bureaucracy to even political leaders and government leadership. So I think that change in mindset is majorly required, and we must acknowledge it. I think the second is, the economic argument also needs to be sound, right? So when in India between 2014 and 2017, there were a few pilot programs that were being operated, which were looking at private sector engagement in 3 geographies in India. And simultaneously, what the donors did, the Gates Foundation, they actually got a costing analysis done to understand how much are we spending on one patient through these models to diagnose and treat them, and how much do we spend in the public sector to treat and manage a patient there. And it turned out that the number was almost similar and actually lower in certain geographies. So that actually made that basic argument to finally the finance ministry to say, look, we don't need to create more infrastructure. We don't need to get more human resources. These are available in the private sector. And all we need to do is to actually scale up these models in different ways, in different, having differences in, different places. But I think that economic argument needs to come out, that we should be using and positioning private sector resources as, in the end, national resources that we need to use. And, Dr. Yasin made that excellent point that there is a deep mistrust, but that needs to be bridged, and, we need to work in a more concerted manner.
Thank you so much, Raman, for that. Yeah, I mean, yes, we need to act in a more concerted manner. If I could move on to Austin. Austin, you have experience in extensive coordinating advocacy efforts for TB care and prevention in Ghana. So what, according to you, has been the biggest challenge with funding for PPM, and what would you say is a strong case to advocate for TB and PPM?
I think I'll start. Yeah, thank you. I think I'll start with the comment from Raman saying that there have not been a systematic way of engaging private sector. I think that's one big challenge, and apart from that as well, private sector does not compromise when it comes to quality. So if we really want to engage private sector, they need to be in the center of that discussion. We cannot just sit aside and make certain provisions in terms of how to engage private sector without them being on the table to be able to have that discussion. When I was the vice chair of the CCM in Ghana, we had Anglo-Ghana Ashanti who were implementing alongside they had a PR, principal recipient, receiving money to implement malaria program. And they were doing so well, with the private sector. I also have a colleague here, Nee Hansen. He is now the vice chair of the CCM in Ghana here. We implemented private sector TB program in Ghana together. And we realized that actually most of the cases are actually in the private sector. When we talk about the low-hanging fruits, they are actually in the private sector, but we are not able to harvest those because of we are not able to engage the private sector in a systematic way that they should be part of that process. And they are keen with innovation, because as long as you engage them, they'll be able to tell you how the best way to actually work with these people, to be able to get the people, to accept those services. I think we need to have very systematic way of engaging a private sector. It may be country by country in terms of how this works, but I tell you that in many countries, we have huge private sector service delivery, which are not really being utilized as better structures to be able to engage than creating new structures that we know that will never end anytime. Thank you.
Thank you so much for that, Austin. Do other panelists have anything to add to this discussion? Or if not, I'll go to a question. Do panelists have anything to add? Vinita, over to you.
I want to answer one very good question raised in the chat by Robin. Is that okay, Ekta?
Vinita, I think the third part is on advocacy, so I was you can respond to her then.
Okay.
But on the topic of PPM, does anyone have anything to add right now? There's a question in the chat. It's from Chelsea. Any of the panelists can take this question. What are some of the best practices the panelists have seen in managing and coordinating private sector engagement in TB? Because private sector is so disparate, which I agree, in most countries. How can we efficiently and sustainably coordinate? Agatha, I see your hand raised. Do you want to take the question?
Thank you so much. Before I can get to the question, it would be nice to mention that in Kenya, through various development agencies, where we have the Global Fund, we also have the USAID. There's a lot of investments in terms of the public PPM engagement. And how are we doing it? There is a system approach to it, where we make sure at the national level we have the technical working groups to steer the private sector engagement, and down we have a devolved system here where we work with the county government, and both of them have actually taken the matter private partner mix engagement quite seriously. And why are we doing this? It's because we actually acknowledge that most of our patients have a preference for the private sector, and because of the reasons the other panelists have actually spoken about, and that is matters quality and access, and the speed at which the patients are actually served. And most importantly, what I would mention is that through the routine engagement of the private sector, we can get over and above the cases that we continue to miss. And this is something we need to keep talking about, just make sure that we don't miss any cases. Who prefer the private sector for care access.
So much for that, Agatha. Austin, do you want to jump into the conversation?
I just want, yes, just a quick one. Just wanted to say that the TB Reach, I don't know whether you heard about the TB Reach that is being implemented through the Stop TB Partnership, funded by Canada government and also USAID and UK government now. Is a very good platform to also get some of the innovations in terms of how to work with public-private mix within the countries for TB. And we've seen a lot of good results coming from the TB Reach. So many countries in Africa and also Asia as well. So it's another platform that we think we can be able to use to be able to get some of those good innovative ideas on how to work within the private sector. Thank you.
Thank you so much for that, Austin. Mohammed, do you want to take that question as well? I see your hand raised.
Yeah, a quick one. We also have been looking at the innovative models which really contribute overall addressing TB in countries, and how those could be expanded as part of a Global Fund support. There are actually several approach or models which are emerging in countries. But I think it's very important that we all are open and see and bring private providers as partners and engage them during planning and implementation. That really ensures sustainability as well. So it's not just looking at the evidence lessons learned only within the country, but we need to open also our eyes to look at what is happening in other countries. Otherwise, there are really good models which are contributing a lot, need to be expanded as far as we are going to address TB. And we have seen also like the India experience from small scale in 3 cities supported by GATE, and that was expanded to over 100 districts through the JIT and the Global Fund support. And now that is transitioning to domestic funding and expanded throughout the country. So they are really good examples and lessons learned from different countries. Context may be different. This could be adopted and adapted to make sure that it is implemented and sustained as well. Over.
Thank you so much for that, Mohammed. Again, I'm conscious of the time. So I'm moving to the third part of the discussion, and Vinita, you could probably take Robin's question at this point. So in the global TB advocacy space, one of the most compelling and recurrent case for investment I see is that when COVID-19 hit, many countries use the same labs, health workers, community systems, and surveillance systems created to fight HIV, TB, and malaria as a foundation for COVID-19 response. So how can we center TB in funding discussions, including conversations on pandemic preparedness, UHC, and antimicrobial resistance? So Vinita, you can also respond to Robin's question right now. Over to you. Vinita, you're on mute.
Yeah, sorry. I'll be brief. So Robin mentioned the question if people have not seen in the chat, and Robin is an excellent advocate, and I don't know if I can count the successes that she has led. So the thing is that this is a big paradigm shift. How can we make it like we as an advocates walk this fine line? We need the money for the implementation. We need to deal with across the board, different type of people, arguments work different. And that also allude to your first question, Ekta, like how do we make case to the policymakers? So we walk that fine line to make the case using our communication strategies to how it will land up to the other side. So sometimes we have to make a self-interest case. Sometimes we have to do, LMIC, it will affect HIC. Like in the COVID form, we say, hey, if you don't do health equity in Global South, it's going to affect you too. Not always our heart is there, but we take our goal and spin it into the communications strategies that would work with the policymaker who hold the purse. Now, that's what we do in the current system, but we need to keep fighting for the paradigm shift. I have seen in 30 years of my advocacy, we need to shift from philanthropic, charity, I give you approach to rights approach. That's the only way to move from the self-investment case to this is the right thing to do, and it's not your choice. That's we need to do, right? So the big supranational philanthropies, all those structures that we have, decolonization of the global health investment we need to do, right? Equitable relationship between HIC and LMIC need to be done. And that's where now the moment is so important. We have one side Global Fund, and I know from personal experience how we as physicians viewed Global Fund. And equitable, where people, LMIC and HIC came together. And then we have something like FIF coming on board where there's no seat for Global South and the CSOs. So we need a paradigm shift. While we keep on making the arguments we make, whether they're cringeworthy for us as an advocates, but at the same time, we need to keep hitting on the paradigm shift. Back to you, Ekta.
Thank you so much for that, Vinita. Funke, I was coming to you anyway. So I want to know, what are your perspectives? You've been such a huge TB champion. So what are your perspectives from the grassroots, and how do you make a compelling case for TB? Over to you, Funke.
Yeah, thank you very much. Thank you. Can you hear me? Yeah. Good afternoon, everyone. Yeah. TB is a deadly disease, which we already know, and we can't rule out the fact that TB survivors are more engaging as regard advocacy and awareness. So if we want to actually achieve a lot on advocacy, we need to still go to the grassroots to play more of our role as survivors, because we actually felt the pain, and to make a suggestion as regard this PPM meeting. If we actually want to scale up and create an avenue for improvement in our health service delivery as regarding TB treatment and regarding investment, we need to actually keep building more capacity through strategic advocacy. I call it strategic because it should be our next plan of action. Not every country gets direct financial assistance from its government. for public sector or private sector to implement PPM schemes. And so with donors' involvement, but by strategic advocacy, we can advocate for more funding, widely necessary for TB case finding and detection, diagnosis, and access to quality care and treatment. We all know TB is a deadly disease and it's curable. So therefore, there's need for more PPM to be a bigger part of the focus. Yeah, I call it a bigger part of focus. Lastly, we also need to push for more advocacy, more for the support of innovative PPM schemes, such as integrative methods and delivery services, which I know that we are all doing already with other health services providers through collaborative efforts, technologies that create more effective engagement and involving more TB survivors around the vicinity and community and country for the TB control programs. And this in a way would create sustainability for existing TB programs here. Thank you very much.
Thank you so much for that, Funke. Does anyone else in the panel have anything to say about how we center TB in funding discussions, including conversation on pandemic preparedness, UHC, and antimicrobial resistance? I mean, I'm sorry for putting you on the spot, Agatha. Would you be able to share some of your perspectives from the grassroots? Okay, you're on mute, Agatha. We can't hear you. Yes. You're on mute again.
Okay, thank you so much for reaching out for that. And in the Kenyan context, our main core is to make TB the topic of discussion, amplifying the voice around TB. And how do we get to do this as a country? Just, human interest stories. I believe stories told by our patients really go wide and round to lobby and really call on financiers to come and do this, to partake in this call to end TB. And most importantly, what I would actually say is that most recently, we have a lot of, working within Parliament, a lot of engaging the policymakers, legislatures, to just make sure that the TB agenda is running in the country. And we also use a lot of data-driven advocacy to speak to this. We have mortalities, but what can we do to avert this? Because most importantly, we acknowledge that a system that continues to miss TB also continues to miss other diseases. And when you make it a multi-disease approach, it actually speaks more in that it takes the system approach and to improve the overall health of the people. Thank you.
Thank you so much, Agatha, for that. Mohammed, did you have something to add to this conversation? Over to you.
Thanks. Just the last point from Agatha. Yes, it's really about people and saving lives and so on. It's not really just about specific disease. We need to keep an eye on TB. All new diagnosis, new vaccine, new treatment, we need that. But unless we expand our access to the basic service overall, unless we really have a strong health system, both public and private at the community level, that's a universal health coverage and so on, we will not be able to address the issue with TB, and we can't accelerate. As we have seen our Global Fund investment case, that we are advocating for universal health coverage, addressing antimicrobial resistance, which will TB account to majority of the deaths from AMR, and also for pandemic preparedness. Given that probably the next pandemic would also be, unfortunately, airborne disease, so whatever investment now we are making would contribute to really building the health system and improving our resilience and preparedness for next pandemic. But in the meantime, we need also to learn from COVID response, where we have seen a lot of new tools and new vaccines and so on within few months, and new diagnostic tools, and the data and real-time reporting, and all these are great opportunities. We need to learn, why not for TB as well? That's why we need to continue advocating. In the meantime, I think the urgent one is that we need that 18 billion for Global Fund Replenishment so that we can contribute to countries to prepare themselves for the next pandemic, but also build a sustainable health system and community system. Over.
Thank you so much for that, Mohammed. I know Vinita and Austin will have to leave. Can you would you be able to take just one question from Robin and before we wind up? So Robin says, how can we shift the model towards a multi-disease approach? In reality, the approach is currently siloed. And does that mean our approach needs to change right now? Vinita, Raman, anyone who would like to take on this question? Agatha, yes. Over to you, Agatha.
Thank you so much. And what I would speak to this is, we keep talking about patient-centered care, family-centered care, and holistic-centered care, because I'll echo again the words that a system that is missing a specific disease will miss other diseases. And how then do we amplify the voice? And in lieu of what can we do to improve our advocacy strategies? One thing I know is if in the finances arena, we need to keep mentioning what progress have we made as far as, the particular disease is concerned. In this situation, we're talking about tuberculosis. Of course, we are not where we were some years back. We've made quite some progress. And we're now looking at how can we sustain so that eventually we can eradicate TB. Having in mind that TB is communicable and it keeps moving. It's a vicious cycle if we don't address it, if we don't start the transmission cycle. So it becomes really important to have what I would call collective responsibility, multi-sectoral accountability, where each and every person, wherever they're actually based, could it transport, health, educationists, all of them need to be at the forefront, because where there is TB, there is TB everywhere, and it affects our people as a whole. So really what I would say, let's take the multi-sectoral collaboration approach towards eradicating TB and towards working together and pulling more forces towards this fight that we have in today.
Thank you so much for that, Agatha. Austin, do you want to quickly add to this?
Yeah, Agatha. Yeah, I think I need to go, but I wanted to quickly say that you see, the Global Fund model has been very effective in terms of it's not just about the 3 diseases, but you see, building health system. If you have a very strong, robust health system, you can actually address a lot of issues. I mean, most of the health issues, and not just building such health system at the central level, but building it at the periphery, so that we don't get people traveling all the way from the rural areas, traveling to the central area just because they want to get quality, health care. So building very strong health system will actually address all the models in terms of whatever we want. So I think Global Fund has actually shown the way. It's about the countries to be able to take it up, because it's the mandate. When you talk about sovereignty, it's the mandate of the country to be able. So everything about the Global Fund is just an additionality that is coming. So they have to be able to live up to that. Thank you. I have to go.
Vinita, I know you have to leave quickly. Just one last question. If you can quickly say 1 or 2 lines on what advocacy means to you professionally and personally, and what program implementers can do in that capacity to push for more investment in TB.
So quickly, like you said, so to me, advocacy is not a separate part of my life. That's my life. That's my lifestyle, right? My first advocacy was at 7-year-old. I was 7-year-old when I successfully did the advocacy. My mom was a political detainee. And then me and my brother advocated successfully that we should be allowed to see our mother after school hours. We could not go during the school when the official. So it's in my blood, it's in my genes, it's generational. So I don't even know how to live without it. Right? Sometimes I get in trouble, I tell you that, but for doing it. So that is from their side. And I just want to quickly say that what other 2 people say, Agatha, if you will allow me, is that multi-disease approach. I feel like we need to put who's in the center. Is it disease in the center or people in the center? And then all these concentric circles around them, which is system strengthening, which is private public partnership like PPM you're talking about, and then disease priorities. Often disease priorities are defined by the donor priorities. Donor defines the disease. So if you put the people in the center, then the whole paradigm would shift where we need to invest. And I think one thing I would leave the audience with is that the hope is not in the people who are wearing suits and sitting in the boardrooms. The hope is in people who are advocating, who are backing and saying, no, we need this, right? So hope is there, not in the people like us sitting and talking heads and no. So we can support their advocacy. We can run as fast as we can in this multi-generational relay race and hand over the baton and make some progress in health equity. And so that's my leaving message. Thank you, thank you, thank you.
Thank you so much for that, Vinita. There's one last action we all can take in this discussion. Petra will put a link in the group. If you can quickly click to tweet, that would be fantastic. Petra, would you be able to put the tweet in the, yes. So yeah, Joel has put the link. If you could go there and quickly tweet it, that would be great. Before we move back to the discussion, because there's the last line of questions for everyone before we close off. Thank you so much. You can also come back to it after a discussion. And Raman, over to you. 2 lines on what advocacy means to you professionally and personally, and what can program implementers of this call do to take action to increase investment in TB?
Yeah, thanks, Ekta. I think advocacy for me, and I was earlier, I was a sports journalist, in fact, and during my studies, as part of my studies was to actually go and cover what they used to call deprivation. And that's where, to really see the lack of access, the kind of struggle people go through was something that really pained me. And that's where I thought that I need to enter this space and, play a small role as much as I can. So that's advocacy for me. And it's been a really great discussion. Thank you for having me here.
Thank you, Raman. Funke, do you want to take this? What does advocacy mean to you? And what can we do to take action? We can't hear you, Funke.
Yeah, thank you. Yeah. Can you hear me now? Yeah. All right. For me, advocacy is we keep talking about what we actually need, what we actually want, and we have to get it until we get it. So, ending TB needs to we need to be more aggressive in advocacy. And as regarding the grassroots, we need to go to the grassroots, get what we want, the case and finding and all that. So it has to be aggressive this time, and that's the next action plan. Thank you.
Thank you, Funke. Over to you, Mohammed.
Yeah, thank you very much. I see that all of you are great advocates for TB and for Global Fund as well. I just want to thank you for on behalf of the Global Fund. But I think we need to, I have seen that for the last 25 years, and that this is a time where we see more advocacy work on TB. We need to do more. We need to be more visible, and we need to also change all this misperceptions and ignorance about TB at different levels. Advocacy is not only in countries implementing the TB program where we have the TB burden and so on, everywhere. And we are happy to see some of our people who have not been involved in TB at all coming to TB after, this lockdown and COVID and the relationship, the huge disruption due to COVID. That is advocacy. And I think we all need to contribute our own part on that advocacy. When you go back, let's advocate to our leadership, to our management and the parliamentarians and our decision and policy makers so that TB will not be forgotten. I think I've seen one comment that most of the TB resource, all diagnostic staff shifted in some of the countries to COVID response, and then we have seen huge drop in TB notification. In some countries that were a quick recovery, And some countries, they are still struggling. I think that part of the advocacy, which would contribute to improving commitment, leadership, and then more resource. So I think we are all doing great job, but we need to continue and we need to learn from COVID, but from HIV as well. And we are happy that you see more people advocating for TB. And that's how we can address advocacy. Is not only for resource, it's really about accessing the service, the available service, but we also need to advocate for more research and development for new tools as well. Thank you.
Thank you so much for that, Mohammed. Over to you, Agatha.
Thank you so much. What advocacy actually means to me is there is a need to keep documenting our implementation journeys. And I'm talking on behalf of the implementers. The small successes that we made, the best practices that we encounter, there is a real need to keep documenting the milestones. That way, in the patient arena, they appreciate that others have gone through this. In the financiers, that is the donors arena, they appreciate that what they give actually amounts to some good work being done down here. And secondly, I would also like to say that there is need to encourage our TB patients, to just journal their stories. There's so many people who do not really, some people don't relate with TB, but how can we pull more people to feel with us, to walk this journey with us? It's just that by amplifying the voice through different voices. Yeah, and maybe towards the end, I'll say it's very interesting to have, a teacher somewhere, a scholar somewhere, really talk about TB. It hits differently when somebody in a different department, different ministry, is talking about TB, because we are used to hearing the healthcare workers talk about this. But if a teacher is there speaking this, then it's become an agenda really, and more schools come to that. Thank you.
Thank you so much for that, Agatha. Duncan, you had your hand raised. Do you want to quickly ask your question if you have a question or an insight to share?
Yes, and a different way of looking at advocacy. For me, information passing, traditionally, ordinarily we would assume that the high-level specialists are well-versed with TB management. And I agree that the need for more investment in TB, mine is towards capacity building, because as much as we would assume that the specialists have knowledge on TB, time and again you'll find that they are not using standard guidelines in the management of TB. So, and again, bringing them together because of their hierarchy, bringing them together to sit in a training of 5 days. So they'll skip many of these trainings, and because they are of their speciality, one would assume they are knowledgeable, but glaringly you find that there are gaps even in their management. So as we are shifting management more, as like in Kenya, where the income is moving from low income to mid income, more people are accessing services in private hospital. Actually, 48% of patients access services in private hospital. And with such glaring gaps in training, for instance, TB-related training for these specialists, then I believe that more investment should go into tailor-making trainings that will work for these specialists. Is it a breakfast meeting we want to disseminate some of this information? Do we also want to target our medical institutions? Because if you look at the curriculum of medical institutions, regimens that were used way category 1, category 2, category 3, and 4, regimens that were outdated long way back are still what are being taught in some of these colleges. So we find our doctors graduating, and already what is they know as the recommended regimens are things that cannot be readily put into practice. So mine is on more funds, but mostly to capacity building. Knowing that these specialists might not sit in for 5 days, how do we tailor trainings for them? Maybe a breakfast meeting or so, just to bring them up to speed to the current practice in the guidelines. So thank you. That's my contribution. I really like the engagement today. Thank you.
Thank you so much for that, Duncan. And thank you all for making it here today. Joel has posted some links in the chat. If you want to join TBPPM, please, please do join the network. It's a fantastic network. I mean, I've personally been working with Petra as well. So please do sign up. Petra, do you have any last words?
I want to thank everyone for your incredible passion, for your wonderful, strong words, your really well thought through ideas on why TB is important for you. I can see it and I can hear it in the words. I can see it in your eyes. Please keep fighting for TB. Talk to anyone that is important, especially in this time. Policymakers, decision makers, if you have any reach, whether it's at the local level, at the national level, to parliamentarians, your voice matters. So we appreciate each of the panelists. Thank you so much. Ekta, you did a wonderful job as a moderator. I just hope that you all take some of the passion and the beautiful words that were said today as the last memory of this meeting today. And I would like to wish everyone a wonderful rest of the evening, a good weekend, and we look forward to seeing you again at our next Friday forum. Thank you all so much. Really appreciate it. See you again soon. Bye-bye.
Thank you. Bye-bye.
See you.
Thank you. Bye-bye.
Thank you so much.